So let's start the last talk of this anemia experts course. And if you realize over the last three talks, we have gradually been building up to a level where we get into greater and greater details of understanding the various disease conditions which could lead to low hemoglobin. Now, the reason the last talk is on MDS is because if you notice the title that I've given, MDS is not an underdiagnosed entity. It is largely an undiagnosed entity. What we see quite often is patients may go on for many years, and I have seen patients who, ultimately pass away without getting this diagnosis. And this was one of the reasons why I decided to have this course in the first place, right? To kind of sensitize all of you to the differential diagnosis and to enable you to understand which patients need a more extensive evaluation compared to those who may just be nutritional iron or vitamin B12 deficiency. So, with that preface, let us start. MDS, the full form is myelodysplastic syndrome. And the meaning of that is very simple. Myelo means marrow. Dysplastic means the cells don't look normal. They're dysplastic, they look weird. And syndrome means it's a cluster of clinical features which this disease has. Typically, because the marrow is dysplastic, there is a problem in the factory itself. The patient will present with either low hemoglobin, most commonly, and over a period of time, they also get low WBC and low platelets. Occasionally, some patients will present with low platelets first, and then later on, or in fact, leukopenia first, and then later on, RBC and platelets may go down. But generally, most of the patients will present with anemia. Uh, Usually, they get misdiagnosed as recurrent nutritional anemia. And what happens is they go to a doctor with low hemoglobin. They get iron replacement or even multivitamin B, folic acid, B12, all that. They will also get blood transfusion because after some time, what happens is the hemoglobin drops to a level where they need transfusion. And they take a transfusion, they feel better, they go back to their house, and a couple of weeks or a couple of months later, they'll come back to the doctor with anemia. And the doctor feels that, oh, maybe this is just a recurrent iron or B12 or folate deficiency, and may do the testing, may give the replacement for these, but also ends up giving transfusion. Now, if you remember, in the nutritional anemia talk, I told you that when iron B12 folate deficiency recurs, typically the patients present with anemia once in 2, 3, or 4 years, not months. That's because once you give a transfusion, that one packet of packed red cells has 1 year supply of iron and B12. So when they receive that, that blood transfusion gives them 1 year supply of iron and B12, and the iron and B12 stores get packed up, and the hemoglobin stays good for a year, 1.5 year, and then 1.5, 2 years later, the hemoglobin starts dropping as the stores get used up, and they would present again with severe anemia, typically after 3, 4 years. So that is the pattern of recurrent iron B12 folate deficiency. It recurs in 2 to 4 years, not weeks or months. So if somebody is coming back to you with anemia that is coming back very rapidly and needs, transfusions far more frequently, then please do not assume that this is just recurrent nutritional. The other problem that we often see in MDS is although the numbers are there, the cells are defective. They may not be functioning properly. And we see this most often with WBCs. In the initial part, WBC numbers are normal, right? So the total WBC count may be between 4,000 to 11,000. The neutrophil percentage may also be good, but these neutrophils are defective, they are dysfunctional. So they exist in the blood, but they are not able to do their job. They're not able to fight infections. So quite often, what happens is, along with anemia, patients will come with minor infections which become serious. So a dental, minor infection could turn into a dental abscess, may require surgery, or there may be recurrent UTIs, urinary tract infections, or the urinary tract infection may become complicated and the patient may have to be admitted for IV antibiotics. Sometimes what you also see is patients get upper respiratory tract infection, which progress to pneumonia, and they need to be admitted for the treatment of pneumonia. So, basic simple infections can become worse. They may become difficult to treat. And that is one of the features that you see sometimes even in the presence of a normal WBC count. So how does this actually happen? How does a patient's bone marrow become dysplastic? How does myelodysplastic syndrome actually develop? What we understand is the bone marrow has something called as stem cells, hematopoietic stem cells. And that means these are stem cells which give rise to the precursors, which then create the RBC, WBC, and platelets. And these stem cells inside the marrow, um, theoretically, one of them picks up by chance picks up a genomic mutation, right? And genes are present in every nucleated cell in our body, right? Genes and DNA, chromosomes, that's there in the nucleus. And genes, our genetics, that is the software on which our body runs. So, like a phone or a laptop runs on a software, similarly, our body, every cell in our body runs on genes. And just like the software can pick up errors, you're all aware how after some time, certain apps or certain programs on your computer may not work because the software gets corrupted. Similarly, when genes get corrupted, the genetic sequence gets corrupted. We call it a mutation. And essentially, what happens is with these mutations, that gene and the protein that it forms it is not formed, and hence the cell does not work properly. So the hematopoietic stem cell gets some mutation, and as this stem cell divides into multiple stem cells and it divides to form erythroid, myeloid, and megakaryocyte precursors, that mutation is then spread. And then those precursors become defective and they are not able to produce RBCs, WBCs, or platelets. Now, these mutations are random and they happen by chance, and they happen over several years. So, what we know is these mutations have to occur, that mutated stem cell has to survive, and then it has to multiply to actually cause the disease. So, this takes several decades, and that is why we typically see this disease in the fourth, fifth, sixth decade of life, because that much time is required for the mutation, the genotype to actually convert into a phenotype and actually lead to a defective bone marrow. Uh, when a patient presents to us, if you look at the old blood reports, if you have, And nowadays, thanks to annual health checkups or regular health checkups, many patients come with a lot of old reports. And if you remember, I told you whenever a patient comes to me, I tell them, get every report that you have at home, in your phone, in your laptop. I want to see every piece of paper that you have. And that, I arrange the reports in a sequence, I tabulate them, and that tells me the story. That tells me the story that the hemoglobin has been gradually dropping or abruptly dropping, whether the WBCs have also gone down, up and down, same thing with platelets. So it's important that you notice that clinical phenomenon, sorry, that laboratory phenomenon, seeing that, this is a chronic problem. It has been evolving, and it evolves in quite a few patients. So that's the incidence. And we probably have over 50,000 new MDS patients per year in our country. So it's not as rare a problem as one might imagine, and hence worth knowing about this. Now let's go into some more details of what exactly happens in the bone marrow. I told you that the stem cells, the genes in the stem cells pick up mutations, and we've already seen that the stem cell is the seed, like the seed of a plant gives rise to flowers and fruits and leaves. Similarly, this seed, this hematopoietic stem cell, gives rise to the whole marrow, and inside the marrow we have the precursor cells, right? The stem cell differentiates a little bit, and it evolves to form erythroid precursor, myeloid, lymphoid, megakaryocyte precursors, which give rise to all the three blood cells. How it happens is initially many years before the patient actually comes to you. This green part is the myelodysplastic syndrome, and this is the time when patient presents to you. And if you go back in time, you will see you actually will not realize that the stem cell was picking up some mutations. And typically, I mean, there are several genes which could be affected. What we know is, DNMT38, TET2, IDH. These genes quite often are some of the first genes to get mutated. And then there are a host of others as well. Now, this is the time when one cell picks up a mutation, and then that cell multiplies and forms a copy, right? One turns into two, two turn into four, four into 16, 16 into 64. So there is a whole clone. There are copies of cells which are created which have the same mutation. And in at this early stage, the RBC WBC platelets are normal. In fact, even if you look at the peripheral blood and the marrow, it looks normal. There is no dysplasia. It looks normal. The cells look normal, because in the initial stage, the problem is only at a genetic level. It has not translated into a phenotype where the cell will start looking abnormal. Yeah. So later on, what happens is, as that clone of cells, which is formed from one cell with the mutation, that clone of cells, it is not able to produce RBC, WBC platelets. It can't do its job. So at that point, we see that the hemoglobin WBC platelets start dropping a little bit, but even at that point, if you look at the bone marrow under a microscope, it looks normal. It's still not become so bad that the shape and the size of the cell, the cytoplasm, the nucleus looks grossly abnormal. Okay. So many times when patients come to us in the initial stage with anemia, leukopenia, or thrombocytopenia, and we do a marrow, we may not be able to diagnose MDS. Now, this is something that you need to remember. Often, what happens is, you see a patient and you suspect it, MDS, and you do a marrow, and the pathologist report says there is no dysplasia, there are no features of MDS, but that could just be the early stage. There are some patients where repeated testing is required. for us to get the right diagnosis, right? Repeated testing. So often after 3 months, 6 months, 1 year, if we don't have a diagnosis, we repeat the bone marrow again. And along with doing visual microscopy of the bone marrow cells, we also send the mutation panel to look at the genetic mutations, the genomic mutations, and how they increase over 3 months, 6 months. In fact, yesterday I saw a patient, an elderly gentleman, about 71 years old. You know, 2023, he had a bone marrow. At that time, and he had only presented with low WBCs. His hemoglobin and platelets even today are very good. So he had low WBCs and got a was that was seen when he had presented with some infection in 2023, and a bone marrow was done. Bone marrow did not show much dysplasia at that time, and there was only one mutation that time, and that mutation was EZH2. Right, there is, it must be here, yeah, this gene EZH2 was mutated. And then again, last month in January, I repeated his bone marrow. Now we are seeing some dysplasia, and now there is an additional mutation, that is ASXL1. So this is called clonal evolution. That means initially there's one mutation, and then multiple mutations are picked up until the disease becomes worse. Initially, only at the genomic level, then you start seeing the numbers going down, then the cells grossly start looking abnormal, where on bone marrow report, the pathology friends of ours might be able to say, hey, look, there's dysplasia. And the erythroid precursors don't look normal. Now they're grossly become abnormal. And several of these patients, eventually, there are so many mutations that it turns into a full cancer, and it turns into a complete acute myeloid leukemia. So this is what happens with time, right? And thus, this is a pre-malignant condition. Just like cervical, the neoplasia of the uterine cervix could eventually turn into cervical cancer. So that dysplasia, this dysplasia, essentially, these are pre-malignant conditions. But to ensure that patients are treated properly for MDS, it is called as a hematologic neoplasm. Even though it is pre-malignant, we consider it to be cancer and treat it like cancer, right? Um, Even in the early stages, so that we do not delay. And once the patient gets converted into acute myeloid leukemia, treatment becomes quite difficult and the chances of success come down. So we have to diagnose and treat these patients well in time. Clinically, what happens? The bone marrow is cellular. You see, I told you last time, these are the bone marrow spicules, and there are holes in the bone marrow. It's like cheese. Bone is like cheese, and in the holes, you have the marrow. And you can see this is packed with cells. That means the bone marrow is actually making more cells to try and compensate for the dysplasia, to try and make as much hemoglobin, WBC platelets as possible. So the bone marrow is hypercellular. There are more than normal cells, right? And at a particular point in the disease journey, pathology, they start looking grossly abnormal. They start looking weird. So, like I had said, these are normal erythroid precursors. This is a macrophage, which carries ferritin, which has iron, and these are erythroid precursors. They take the iron from the macrophage and they mature and form into a complete mature RBC and a nucleated RBC and then an RBC. This is how a normal erythroid island looks in the bone marrow under microscope. On the other hand, this is dysplasia. That means you see the cytoplasm now has vacuoles, and the nucleus seems to be budding. Sometimes the nucleus seems to have broken up. It's called karyorrhexis. So the nucleus and the cytoplasm and all of that starts looking weird. We start seeing this protrusions from the cell membrane. So this is erythroid dysplasia. What about myeloid precursors, which, right, the myeloid blast, which gives rise to promyelocyte, myelocyte, metamyelocyte, band cells, and neutrophils? This is the normal maturation. However, In dysplasia, you see this neutrophil. The neutrophil nucleus seems multilobular and broken. It just doesn't seem normal. It looks weird. And the cytoplasm does not have granules. And those granules have the chemicals which kill the bacteria. So you understand, I told you some time back, the neutrophils may be there, but they don't work. They don't work because of dysplasia. They don't have the granules. Because how a neutrophil kills bacteria is phagocytosis. It eats up the bacteria, and the bacteria goes inside the cytoplasm, and then the chemicals which are in the granules in the cytoplasm of a neutrophil, they kill the bacteria. But if because of dysplasia, granules are not there or they don't work, patients will get infection. And what about the platelets? You see, this is a mega karyocyte, mega being big, the biggest cell in the bone marrow. This is the nucleus. It is normally multilobate, normally. Yeah. You can see this cell is so much bigger than the other myeloid and erythroid precursors. And the cytoplasm is fuzzy. The cell membrane is fuzzy because it is a cell membrane which is breaking off in pieces. And those pieces are called platelets. So this is how a normal megakaryocyte looks. But in MDS, myelodysplasia, this megakaryocyte is smaller than normal. It is called as micromegakaryocyte. And the nucleus is not lobulated. It's dysfunctional. It is not able to develop the normal shape. Right. So this is what dysplasia looks like in the bone marrow. And there have to be at least 10% of the cells have to have these features for us to say this is MDS. So that's the rule, 10%. So 10% of erythroids should look abnormal, 10% of myeloids, and 10% of megakaryocytes, roughly. So that is how pathologists will report. And because these are abnormal, they can't do their job. There is a production problem. RBCs, WBCs, platelets are not created. So how do we evaluate these patients? And history and examination, by now you've understood, patients will present with anemia, and usually, but some patients at initial presentation itself, more than one cell line may be affected. So they may present with bicytopenia or pancytopenia, where all three RBC, WBC, platelets are low. Um, what typically happens is it may seem to be acute in patients. Usually it is chronic. The story goes over a few months or years. But in some patients, they may say, no, no, doctor, I was absolutely fine. And I started feeling breathless last week. Then we did a CBC and my hemoglobin was low. At that point, if you look at the old records, you will see that it is actually not an acute problem. The hemoglobin has been dropping for a few months or years, and so on and so forth. On examination, generally there is nothing other than pallor. You won't have icterus, you won't have hepatosplenomegaly. I mean, there may be mild splenomegaly in some patients, especially some complex syndromes, but generally on examination, you will not find anything. And that is why you may be misguided into thinking that this is just nutritional anemia, because on examination, you are not finding any organomegaly. But if the problems are recurring too rapidly, then please evaluate further. One of the hints in a complete blood count is in MDS patients, it's kind of like megaloblastic anemia, that the nucleus is not able to mature and the cytoplasm keeps on growing. So these cells are larger than normal, except the megakaryocytes, which are micro. So the RBC size is also bigger, and the MCV is slightly higher, around 90, 95. And sometimes even pathologists may be mistaken and say, no, no, this is megaloblastic anemia, but it actually be MDS, because both look very similar on under the microscope. So a high MCV, macrocytic anemia, which is recurring, maybe multiple cell lines are affected, and on peripheral smear, you will ask your pathologist, hey, really, are the WBCs low, platelets low? Is this true cytopenia? And do the cells look normal? Are they dysplastic? Are there any blasts? Blasts are the blood cancer cells. So blood cancer cells are called blasts. Um, If the blasts are in AML, they're called myeloid blasts. In ALL, they're called lymphoid blasts. In MDS, you will usually get AML. So if you're seeing more than 5, 10, 15% blasts in the peripheral blood itself, then you would start thinking that maybe this is not MDS, maybe this is AML, or maybe this MDS has already progressed to AML, right? So this is what you will look for. And then you would do a bone marrow. Now, when you do a marrow, it is very important to collect some extra marrow aspirate. What we do is when we do a bone marrow aspirate, we will take minimum two EDTA tubes and two heparin tubes. Typically now, you collect bone marrow aspirate in vacutaneous. So at least two EDTA and two heparin tubes. Why? Why not just one? And of course, you will also do a biopsy because there are some MDS features on biopsy which are important. I'm not going into all the details because they're not so important for you, but you have to do a biopsy every time and you have to collect some extra vacutainers, EDTA, heparin, etc. Why? Because from the EDTA vacutainer, the pathologist will make a film, just like peripheral blood film, they'll make a bone marrow smear and stain it and look under the microscope for all the pathologic features of dysplasia. But the other tubes that you have collected, the other tubes will be sent for genomics. And today, in today's clinical medicine, if you start talking about clinical genomics, then there are four types of tests which we do to look at mutations. So you do a karyotype where we look at all the chromosomes, or you do FISH where certain mutations are looked for, or you do PCR or a next generation sequencing NGS panel. Now, this is very important because remember, in the early stages, you're only going to get genomic abnormalities. You're not going to see dysplasia also, right? So that's why it is important to collect these extra samples. If your pathologist tells you that, oh no, there is something abnormal, this may be MDS, then you have the samples in the fridge, which you can then send off for genomic testing. Otherwise, what happens when the patient comes to us, we have to repeat the bone marrow test. On the other hand, if you call me and say, hey, Sachin, I have a patient, looks like MDS, don't worry, I have some extra vacutainers. Of course, they should not be too old, just maximum 1 or 2 days old, and I'm sending you the patient with the bone marrow vacutainer. Then I don't have to repeat the procedure, right? Because the samples are already there. And with all of this information, we then diagnose MDS. Now, I want you to start with this. Now, this table gives us the classification of myelodysplastic syndrome. What are the types? How do we categorize the patients? Because MDS is not one diagnosis, right? That within myelodysplastic syndrome, patients are different. Some have only one cell line affected. Some have bicytopenia. Some have pancytopenia, right? And in the early stages, they will not have too many blasts. Whereas in the later stages, the percentage of blasts in the marrow, normally it is less than 5%. It may go, 5 to 10%, 10 to 20%. And as it goes to 20%, beyond 20%, we'll say, well, now this MDS has progressed to full leukemia, full AML. So depending on the percentage of blasts, we classify the patient. Depending on the mutations which are there are different names for individual MDS. So there is MDS with low blast and 5q deletion. That means in the fifth chromosome, if you remember, every chromosome has a short arm and a long arm, right? It's like every chromosome is like an X, right? Chromosome 1, 2, 3, 4, 5, 6. It looks like an X. So there's a short arm and there is a long arm. So in the fifth chromosome, fifth chromosome, Q, long arm. So short arm is called P, long arm is called Q. So fifth chromosome, long arm is deleted. It's absent. These patients have anemia but normal WBC platelet counts. And these patients, there is targeted therapy. You just have to give tablet lenalidomide, and they do very well for many, many years. This is a disease with very good prognosis. This is a subtype of MDS with very good prognosis. Similarly, some MDS patients will have mutations in the SF3B1 gene. We find this on a PCR or a NGS testing. SF3BB1 also has a targeted therapy. There is an injection luspatercept. When you give luspatercept, these patients do very well for many, many years. The chance of these two type of subtypes of MDS evolving to AML is very less, right? So this is a good prognostic. On the other hand, if we have a TP53 mutation, then that's poor prognosis. These patients will progress to AML very rapidly, and hence you have to rapidly plan a bone marrow transplant, a stem cell transplant for them. Sure, you start with medicines, but you have to plan for a stem cell transplant. If you don't do it and the patient progresses to AML, after that, even the chances of success of transplant come down, right? So, this is how we classify and prognosticate. Now, there are several prognostic scores which are available. IPSS-M is one of the most widely used. M stands for mutation. Yeah. So you see the percentage of blasts in the marrow, how low is the hemoglobin, how low are the platelets, what are the mutations which are there. Based on this, as per this score, patients are categorized into six groups. So there is the very low risk, medium high, high, and very high risk. So typically, very high risk patient will be somebody who has really, excuse me, who has really bad mutations like TP53, right? So these very high risk patients, you see leukemia free survival. So if you start with 100 patients at diagnosis, how rapidly they get leukemia. So you see by the end of 1 year itself, 50% of them have progressed from MDS to complete cancer, AML, right? So it's a very high risk MDS. Whereas very low risk MDS, even at 10 years, 50% only have gotten converted to cancer. The other 50% are still free of cancer. So very low risk, etc. We categorize. That helps us counsel the patient. That helps us tell the patient that, hey, you're very low risk or low risk. Probably you don't need a transplant for a few years. We're just going to treat you with medicines, and chances you're going to respond very well. And your also lifespan can be predicted. So this is the overall survival probability. You see very low risk at 10 years. And remember, these are patients who are in their 40, 50, 60, 70 years of age. So at 70 years of age, if I diagnose somebody who is very low risk category, so excellent prognosis, I can tell them that, even after 10 years, only 50% would have had a problem. On the other hand, you look at the very high risk. By 4.5, 5 years, only 10% are alive. 90% would not survive, you know, and even after transplant, they may not survive. So this is how we prognosticate the patients depending on how low is the hemoglobin, how low are the platelet counts, what is the mutation, and accordingly we categorize them into six risk groups. How do we treat them? Supportive care, this goes, without saying, hemoglobin less than 8 in a production problem, you have to transfuse with packed red cells. Platelets are going, to 10,000, or if there is bleeding, even at 20, 30,000, you may have to give platelet transfusions. Because of low WBCs or dysfunctional WBCs, they will get infection and you have to treat those infections. We also check the serum erythropoietin. This is the endogenous erythropoietin that is made by the kidneys. What happens is, whenever there is anemia, the kidneys will secrete erythropoietin in the blood. And this chemical then goes to the marrow and stimulates the marrow to make more hemoglobin. Right? So this is a cycle. So there's a feedback that the kidneys give to the bone marrow to say, hey, you have to increase or decrease the production of hemoglobin because the hemoglobin in the blood reaching us is less. So if the endogenous serum erythropoietin is less than 500, then we just give the injection like it is done for CKD patients, right? Chronic kidney disease patients. So you can supplement erythropoietin, and that increases hemoglobin in many patients. Um, and then the next thing, so after supportive care and erythropoietin, the next thing, like I had said earlier, is there any targetable mutation? If there is a 5q deletion, lenalidomide, one tablet, phenomenal response in the majority of patients. For several years, the disease stays under control. They don't need anything, just regular CBCs after that, right? Similarly, if there is SF3B1 mutation, luspatercept injection, fantastic response for several years, patients will remain stable. However, if they don't have a targetable mutation, then you have to give a broad therapy. This is done, the primary backbone of treatment are these two medicines, azacitidine and decitabine. Okay, both are available as injections. Azacitidine is also available as tablet. Now, what are these medicines? These are called as hypomethylating agents. Hypomethylating agents. What was understood almost 15, 20 years ago, what scientists found out is in the nucleus of an MDS patient's bone marrow cell, in the nucleus, there are genetic mutations. But the way genes are placed in the nucleus is the genes are folded and they are packaged and methyl groups get attached to the DNA. And whenever methyl groups are attached or not attached, based on that, the gene will become active or inactive. Correct? It's like saying that my laptop has all the softwares. It has Microsoft Word, it has Zoom, it has Microsoft PowerPoint, but I have to open the software to use it. Similarly, every cell has all the genes, but all the genes are not active. The genes which are active in a muscle cell are different from the genes which are active in a erythroid precursor. So how is it that some genes become active and some genes remain inactive? Is by methylation, histone acetylation. There are a couple of biologic processes which happen. So what was found out about 20, 30 years ago, that in MDS patients, not only is the gene mutation, but even the gene activation and inactivation is abnormal. Even the activation and inactivation of genes is abnormal. So there may be no mutation, but if the gene is suppressed or unnecessarily activated, it can create problems. So these medicines, azacitidine, decitabine, they are hypomethylating agents. They improve they improve and try to normalize this activation inactivation of the genes. So this is really biologic therapy based on genetic research, right? And to this we nowadays add another tablet called venetoclax, which is also a BCL2 gene inhibitor. So these together work beautifully even if there is no targetable mutation. How beautifully? Majority of the patients will respond in an average of 2.8 to 3 months. Yeah, 50% will respond and 50 and more will go on responding. And over about 6 month period, 60 to 80% of patients respond. Respond means the hemoglobin starts going up. They don't need transfusion. Their WBC start going up. Their infections come down. Platelets start going up. So the response in MDS is very simple. RBC, WBC, platelet production improves. Yeah. So almost 60 to 80% of patients will respond pretty fast. And after some time, you don't have to worry about supportive care. Right. And this response stays for at least 2 to 4 years. So even if there are no targetable mutations, there are tablets available which can control MDS for a long time. And not only do they control, they will reduce the risk of getting leukemia. They will improve the lifespan as well. However, when these medicines don't work, or they will initially work and later on again the hemoglobin will drop or WBC or platelets will drop. At that time, nothing is going to work. At that time, you have to replace the stem cell. The stem cell is mutated, damaged. You have to replace the stem cell. You have to do a stem cell transplant or what we call bone marrow transplant. It's the same treatment. So you need to do this because this is the only cure. None of these other medicines are going to cure MDS. They're only going to control it for a few months or years, right? And eventually, majority of patients will relapse. So if you want to cure, stem cell transplant, right? And this is done for advanced disease. Like I showed previously, the disease is progressing, the hemoglobin and all that is very low, high supportive care is required, and or the percentage of blasts is increasing. You're worried now this is going to convert into full AML. So that's advanced disease. And for those patients, we do a stem cell transplant. But mind you, I told you most of these patients are middle-aged and above. And if they come at a very late stage, beyond 70 years, they may not be fit for a transplant. So that's a problem. Not everyone can be cured. They have to be fit. The patients in this age group also have a lot of comorbidities. They may have coronary artery disease, they may have cerebrovascular disease, diabetes, blood pressure. So all of that also affects the chances of success of treatment, especially in MDS, because it comes in that age group. So practically, what are you going to do when you have your patients, right? Like I said, you have to watch for those patients in whom the anemia is recurrent very frequently. This MDS was previously just called refractory anemia. That was the name. And later on, it was understood that this should actually be called MDS, myelodysplastic syndromes. So, so whenever you have patients who have refractory or recurrent anemias, you need to rule out other things, right? The goal is not to just assume that this is nutritional. So what else can be? Okay, maybe the patient did not take iron sufficiently. Most of the patients will take tablets for 1 month or 2 months, and the hemoglobin improves, and then they stop. So their iron stores are not filled up. You'll of course see whether they have taken the treatment properly. You will see if you've missed a vitamin B12 or folate deficiency. You will look for losses, blood loss. You will do a stool blood or upper or lower GI if you think that should be done. You would also do the iron profile, not just ferritin. You will also start looking at serum iron and TIBC and seeing if there's anemia of chronic disease. Hypothyroidism is again something that gets missed, especially in men. Women often undergo a thyroid function test. So hypothyroidism may also cause or worsen anemia. We need to remember that anyone with any recurrent blood related problem, please scan the abdomen, at least an ultrasound abdomen, look for cirrhosis, hypersplenism. So often it gets missed. There are other rarer causes, of course, of recurrent refractory anemia. Many patients, because of either gastric reflux disease or an ulcer, they are on chronic antacid proton pump inhibitor therapy. And that reduction of gastric acidity can lead to iron deficiency. They may have malabsorption, and we did briefly mention about malabsorption due to celiac disease that actually could be causing recurrent iron deficiency or even B12 deficiency. You are aware of pernicious anemia. So you look at all of these things. You also start looking at, once you have ruled these out, or if there are multiple cell lines which are affected, you would do a bone marrow test. And in the bone marrow, either like we have discussed previously, either there are no workers or there are bad cells, as in leukemia, myelodysplastic, myeloma, lymphoma, etc. And it could be marrow infiltration due to solid tumors. So if you have a patient who falls into refractory recurrent anemia, please have an open mind and look for these uh, entities, and don't just transfuse or give injection iron B12 repeatedly. This is something that I wanted to show to you, that if you look at RBC, WBC platelets, then and this is going back to some of the uh, 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 charts that I've shown you. Either there can be decreased production or increased loss. And in this, B12 folate, bone marrow problems, either bone marrow failure or infiltration, these are the three conditions where actually multiple cell lines can be affected, right? So if you're getting more than one cell line being low, then start thinking of maybe there's B12 folate, maybe the bone marrow has failed, maybe the bone marrow is infiltrated, and most importantly, there is a concept which I call high risk cytopenia, where I want you to really consider good evaluation of patients where more than one cell line is affected. They're not responding to your treatment, or the hemoglobin WBC platelets keep on going down, initially improves and goes down recurrently, or there are prolonged problems. For example, classically, dengue fever, platelets should start recovering in 2 weeks, but they are not recovering. Or even in iron deficiency, B12 deficiency, you're giving replacement, but the patient is not, hemoglobin is not increasing as rapidly, so there is prolonged problem, right? Or there is organomegaly, lymph nodes, liver, spleen, etc. Or your pathologist mentions atypical cells seen. Take that seriously. That may be something wrong in the marrow, right? Or the WBC differential is not normal, or you have recurrent infections. Or if you feel nothing is working, I'm going to give some steroids. Please don't do that. In these conditions, evaluate the patient further. Do a bone marrow exam. If there are lymph nodes, do a CT scan, PET CT, whatever. But these are patients who need more deeper and more detailed evaluation. So that is it about MDS. And, thank you so much for being part of this. This was our last talk, although we will have one more on Tuesday, on a stem cell transplant. And I'll give you some overview of how we do bone marrow transplant, stem cell transplant. And after today's talk, most of you have already done the pre-test. You please do the post-test. Now, today's post-test is a bit different because when you finish today's post-test, you will see that there is a link to download your certificate. So you click on that, your certificate, you can then download as a PDF, and you can print it and frame it if you like. So let's start taking questions. So, drug dosages details in MDS, I have purposely not gone into it because there's some nuance to it. It also depends on, in some patients we'll only give azacitidine initially, or we choose to give decitabine, or you'll give tablet azacitidine, for which there's some data. In some patients, we'll combine venetoclax. The venetoclax dose also differs based on whether you are giving any antifungal. So the doses are a bit complicated, and that's why I didn't get into the details of these. As and when you have patients, discuss this in detail. Um, Cost effective test at periphery. Apart from peripheral blood, there is nothing more cost effective than peripheral blood smear, right? And once you've done a CBC, the minimum that you should do, even in the periphery, is a peripheral blood smear. There is nothing less which is more cost effective than that, and that is a minimum essential that has to be done. Basics of treatment and protocol, like I said, there is some nuance to it. There are multiple protocols and regimens, and that's why I've not gone into details. How risky is stem cell transplant in MDS? Good question. And on Tuesday when we have the talk on stem cell transplant, I will address this. It's of course a complicated procedure, and the risk of stem cell transplant is typically divided into three parts. Okay, three parts. One is what is the what are the different morbidities that the patient has, including the age. What is the age? What are the other organs which may have a problem? Does the patient have like I said, coronary artery disease, or is there liver dysfunction, or is the creatinine high? So what are the overall, what is the health of the patient and the age? That's the first part that we look at for complications during transplant. The second part is the disease. What is the disease? So, for example, if we have an aplastic anemia patient who comes, young patient who comes rapidly for a transplant, the chance of success is up to 90%, 80 to 90%, right? So, the disease matters. Similarly, a thalassemia child who comes within 5, 7 years of age, they're still healthy. They don't have major iron overload. Again, 80-85% chance of success. On the other hand, if it is advanced disease, if it is MDS, which has already progressed to AML, and there are bad mutations, then the chances of success are less, right? So that's the second part. So the patient-related factors, the disease-related factors, and then, of course, there are complications. So during transplant, there can be complications such as infections, organ dysfunction, blah, blah, blah. And, graft versus host disease, viral infection, CMV reactivation. So all of these put together determine the risk of transplant. But today we are able to manage this in the majority of patients, provided we do the treatment early and we do it in a proper manner. So MDS looks initially similar to aplastic. When to suspect? You can't suspect. Both MDS and aplastic will present with, either single or bi or pancytopenia. You have to collect extra samples for all patients. So our policy is that whenever we do bone marrow, for whatever condition, we always collect extra samples. There is it, because you don't know what the marrow is going to show. There is no way without a marrow you can guess whether it is MDS or aplastic, or even solid tumor infiltrating. So you just have to collect extra samples. MDS, do we see in children? Yes, much rarer, and but it can be seen. And in overall, the prognostication and all that is almost similar. Can a sickle thal patient develop MDS in due course of time? No. In sickle and thalassemia, the mutation is only in the globin gene. The mutation is not in the other genes which can lead to MDS. Hence, these patients cannot develop MDS on their own, right? Sometimes in small number of patients, once they undergo transplant, sickle or thalassemia patient undergo transplant, then post transplant there can be secondary malignancy, but that's usually less than 5%. On its own, sickle and thal cannot develop MDS. Dr. Saida is asking, is there any specific presentation of treatment related MDS? Of treatment related MDS. So this is a very good question, and I did not touch upon that. So what Dr. Saida is asking is treatment related MDS. That means treatment which causes MDS. Now this is typically seen in malignancies, in cancers. So patient has breast cancer, or colon cancer, or even leukemia, and you have given chemotherapy. Now that chemotherapy is supposed to kill the cancer cells, but at the same time it can also damage the genes and induce mutations. So about 5 to 8% of all patients with who have received, excuse me, 5 to 8% of all the patients who have received treatment for cancer after a few years can develop a second MDS, a second cancer, that is MDS, which is because of the side effects of chemotherapy, right? The toxicity of chemotherapy. But that happens in 5 to 8% of patients. 92 to 95% do not, right? And Dr. Saida, what you've asked, treatment related, chemo induced, radiation induced MDS, they're all the same. Um, all right, wonderful. Thank you so much, all of you. And remember, complete the post test. Put your email ID correctly, because it might even get emailed to you. Make a password, any password, 5, 6 letters, and make a password. Complete the post test, and then download your certificate. And I sincerely hope that uh, this course that we have taken and many more courses that we will have will help you in diagnosing and treating and following up your patients. In my mind, even if one patient benefits from this, this was a worthwhile exercise. And thank you so much.